When you look at the arch now, what is the gold standard for treatment of an arch pathology? There's no question that the gold standard is replacement of the arch, and this meta-analysis was done with basically 64 studies, almost 8,000 patients. 30-day mortality was 8.9%, stroke rate was 7.1%, paraplegia 3.4%, and renal failure was 14.9%. And if you look at the ages, the male morbidities is the usual player. Smokers, the usual players in vascular disease. These are the cohorts of these. And these findings in the previous meta-analysis were confirmed by the study that looked into STS database, the STS arch strategies. So they looked into 12,521 aortic arch repairs from 2011 to 2014. They had basically only 7.5% of these cases were total arch replacement. Overall mortality was 12%, stroke rate was 8%. So it's comparable to the previous study, although the mortality here is higher. And here they looked at the redo versus non-redo, again for the arch and for proximal redo. So obviously they found that there's more mortality or less survival with redo in the proximal, and possibly comparable studies with the comparable results in terms of the arch redo in experienced hands. So what are the tape blight? I mean, this is a great repair, everything is good, but what can happen with these repairs? You can have additional aneurysm in the residual aorta. A lot of times people would put a graft and then they would patch. They do like Corel type of patch for the head vessels or the arch vessels, and these can become aneurysmal. These can dissect. Pseudoaneurysms from anastomosis can happen. Infection of prior stent graft. And you see, this is this is somebody who had, it's an illustration of somebody who had a patch repair, and the patch got major aneurysm right now. So frozen elephant trunk results, again, this is single study for 100 patients in Germany. Mortality is 7%, stroke 9%, paraplegia 7%, and dialysis. So the numbers varies between studies, but they're pretty close. So this is not a walk in the park procedure. This is a very difficult procedure that has basically bears mortality results. When you look at the newer, and this is the frozen elephant trunk, so what it is, you replace the arch and you put a stent, and I didn't really want to go in details, but there's a device called Thoraflex that's been used. There are multiple devices are used now. There are devices or grafts with bare stents are being used right now for that. But I wanted to discuss a modified frozen elephant trunk, which basically you have a patient with type A dissection. They treat the type A dissection at the same time in the OR. They would place a descending stent, and the survival rate with this technique, if you have time and you know how to do it, has been they showed improved survival with these patients. In our institution, they do this quite frequently. Almost every patient who can tolerate the modified frozen elephant trunk basically they'll get it. There's a lot of patients in our institution that they come with this now. In this slides you see essentially the techniques for open repair of any arch pathology. There are different ways of doing it, different deep branches. Sometimes you leave a patch and so forth. But the point of this slide that there are many ways, and like anything else, like aortobifem, triple A's, anastomosis get fatigue, and you can develop pseudoaneurysms years later. These connective tissue disorders, especially if you use a patch, this could be. With hybrid procedures, they are not as commonly done now that the other endovascular technology are available. You see the mortality rate still high, depends where you do it. If you compare it to open surgery, it's about 0 to 15%. Stroke rate is lower than open surgery, but endoleak here is about 20%, and that's a lot. In another studies, in another slides or chart with two studies, again stroke rate is about 11% to 11-12%. I'm sorry, there's a mortality rate about 11-12%, stroke rates about 7-8%. So within the range. Spinal cord is higher in one studies than the other, but the point is, hybrid procedures they're not minimally invasive, they're big surgeries, and they don't work as well as even the newer, I believe, endovascular treatment. This is an example of hybrid procedure where it was ascending an arch debranching, graft taken off the ascending aorta, as you see here, and it's debranched to the carotid and to the innominate arteries with a side branch where you deploy your antegrade TEVAR in this case. But this is another hybrid procedure where a patient had mechanical valve, had large 10 cm pseudoaneurysm, redo chest. So we elected to go from the descending aorta to debranch the cerebral vessels in the neck, actually. And in this particular case, we tunneled thoracoscopically as well under vision, and then placed a stent graft. But my point is, they're not as being done as much as we used to do them before, and they have also endoleak and their own set of problems. There are multiple devices on the market. The Japanese outer branches, there's Terumo and Cook inner branches. There's a Gore device, one branch, and Endospan. There are devices has scallops and has fenestrations. There are multiple options on the market right now, but mainly the main thing or the main devices are used are the fenestrated custom or standard branches, as well inner branches or outer branches, but mainly inner branches now, the most commonly done, and in situ creation, which is usually laser in situ or RFA in situ, with usually typically for emergency. Gore has developed a lot of newer stent grafts. There's an arch graft up in trial. There's a single branch for the innominate, and the TBE was approved, which is the thoracic branch, approved by the FDA, which has pretty good outcome. We used a lot of TBE. We used it for trauma, for dissection. It decreased the amount of left carotid subclavian bypasses that we do. We still like to do them because we have trainees and we like to teach them, but this one of those surgeries probably in the future is going to be less and less. It's going to be done less and less, and there'll be a fewer people to know how to do it. And if you look at this graft here and pictures, there are multiple stents. Again, there's ascending stents with a cuff, and that on the left hand side box here. The stent with the cuff, well, it gives you more flexibility to use in the ascending aorta. There is innominate branch that is being used with extra anatomical bypass. There's subclavian branch. There's a lot of stuff that now Gore has available. And other companies as well, such as Endospan. Endospan, they have a single branch graft, and now they're working on a second branch, I believe. This is a TBE device, which is the subclavian branch for type B dissection. You see, it was very difficult to get a landing zone, but you see the wire snared into the subclavian, and you see here the revascularized portion of the subclavian looks pretty good, and it's very quickly. You can really do it, like I said, in about 45 minutes to an hour at the most. In this slide, where you see a single branch device, gore device. In this case, there's a stent being placed in the innominate vein. The patient underwent a right carotid to left carotid artery bypass, and then left carotid artery to left subclavian artery bypass. The patient had a penetrating ulcer, as you see down in the inner portion, the inner part of the aortic arch. And the final picture, what you see here, you see basically totally, completely excluded, and this repair is a pretty durable repair. And again, we saw this earlier in the device called Endospan, that's still in trial, but this is not approved yet. And this is a CT scan, was done a year later, and you see the stents are wide open, and this is pretty good results. Chimneys, in this day and age, chimneys really should be used for emergencies. If you have an emergency, and you have no other options in the middle of the night or during the day, whatever time, it's usually emergencies when you use chimney. Or you have no options. Sometimes in the US, unfortunately, we don't have approved arch grafts. So sometimes some institutions have to do either custom made or chimney or things like that. But chimney has a lot of significant type 1A leak. It's 11% intra-op, 50% resolves about 30 days, and this is true. We've done recently a two branched device for the arch. The left carotid artery stent had significant leak immediately on the final picture. We left it alone for about a month or two, and then it completely resolved, and now patient does not have any endo leaks. So you don't need to jump the guns for these type of leaks. Similarly, in a branch device in the abdomen as well, sometimes if you have a celiac or SMA branch or renal branch that leaks, usually it's worthwhile waiting a month or two, and then you need to make a decision, unless the aneurysm is getting bigger, of course. These are studies, three studies that showed basically type 1A leak between 6 and 11%. As you see here, stroke rate is it's within norm, within the standard of these procedures. It's about 4% actually. It's on the lower side. This is how chimney looks like. You see the overlaps with the stents, and pretty complicated when you do it. There's always risk of stroke, access complication, etc. The big question is the long-term durability, which is really in the arch. I don't think we have a lot of studies that showed any long-term durability yet. In situ fenestrations or laser fenestrations or RF fenestrations are very popular now. There's ideally to be done in emergencies, but again, if you don't have any options, you don't have any devices, people have used that. In this multi-center analysis with 25 patients, the stroke rate was 12%, which is fairly high. I suspect primarily because essentially there's mostly people cut down on the carotid bilaterally here, and that also probably has to do some arch manipulation and so forth. But this is, in my opinion, should only be used for emergencies, and the intervention rate is quite high in these cases because when you do laser fenestrations, it depends on the fabric. Dacron fabric would hold the stent more, but you can't really seal very well immediately. So there's a high rate of intervention. If you go on PubMed, there's a lot of in situ fenestrations, laser fenestrations, especially in Asia for type A dissection, acute type A dissection in non-surgical patients, etc. This is a case that basically with someone with PAU, 77-year-old male with PAU, and you see the laser fenestrations, and this is the final picture. Again, requires some cut down on the carotid bilaterally, and that's in and itself can be hazardous. But these are emergencies. I believe it can be done in elective cases as well if you don't have any other options. But the intervention rate is quite high. Long-term durability is still in question. These two Japanese trial, they have pretty good outcome. The branches are, see the stroke rates 3 and 11. The branches, 1 branch, 2 branch, 3 branches. They're not inner branches, they're outer branches. Deployment is difficult. I have never seen these devices. I have never worked with them, nor I've seen anybody uses them here. But the data they have a really good data with them. So, and I don't think commercially they're popular now in part of the world. People are moving towards inner branches and so forth. These are other options for fenestrations and scallops. The endospan that we talked about earlier, if you see this device that usually has it's a IDE trial, clinical trial currently in the US. It's 1 or 2 branches with ascending component. Ascending component becomes very, very handy in these cases. As I mentioned in the beginning of this presentation in part 1, that the ascending aorta becomes some very important part of the arch. Oftentimes you have to land your graft in the ascending aorta. In this case, what you see here, again, a PAU or pseudoaneurysms, and the carotid bypass, carotid bypass. It's similar to the Gore case that I showed you, but that's another device being on trial right now for these devices, for these basically the conditions. This a study that looked into fenestrated endovascular repair of the arch disease, and the study, about 27% of the cohort in the study was zone 0, 62 was zone 1, and 11 zone 2. Technical success was about 95%. Mortality is high, still 9%, but that's probably a little bit higher than average for these cases. Stroke rate compatible with the literature. These are custom-made devices. Again, the choice whether to do fenestrated or inner branch device, it really depends on the case. More and more specialists now moving towards inner branches. Long-term durability, again, we don't know. These studies are not. These cases they have not been around for a very long time yet. This is a really double branch outcome in multiple studies. Essentially, if you look at the average stroke rate, it's a little bit higher than the literature, and I think that's what has been also our experience with the Terumo device. They're good devices, a little bit harder to deploy, to access the inner branches, but they're doable. They're available in trial in the US. So unfortunately, nothing approved in the US for these. In Europe, I believe it's approved, and hopefully it'll get approved in this country as well. So the principles of a double branch device, as you see here, double branch arch device, as you see, the carotid subclavian bypass is done, and you cut down on one carotid, you access the other carotid from the high brachial or axillary, you deploy your graft, and you cannulate your inner branches and you stent them. And that's really the general principles for that. And as you see, so you see these two stents here. You can choose different stents. Sometimes the innominate you require a larger stent usually, and also the remember that innominate splits into the carotid and subclavian, so you have to keep in mind that length and the between the inner branch as well as the bifurcation. And these how they look like, the Cook and Terumo. So the studies of branched endovascular arch repair basically look at multiple cases throughout the world. It's still big surgery, still the stroke rate this is older review. Stroke rate is about basically 9%, 8.1 mortality. So these are not really even the minimally invasive procedures are complicated, associate also with certain blood loss, but the morbidity is high and the stakes is very high as well. This one has to keep this in mind, and these procedures have to be done again with in institutions who have experience with them, with multidisciplinary team. It's not a one-man show. You have to have good anesthesiologist, good vascular / endovascular operator, CT surgeon. A lot of CT surgeons nowadays, they do also have or pose wire skill. So it's very important to have a team in place and approach it as a team. In this study done by multiple international operator who are doing these cases on a regular basis, 70 patients, 100% prior type A dissection with open repair of the ascending aorta. So when you have an open repair of the ascending aorta, essentially you have a good landing zone, and basically the combined mortality and stroke rate were 4%, which is pretty low. Technical success was about 97% in this cohort. This is a study that we had done. This patient, young patient with multiple heart surgeries and stent in the past, had a pseudoaneurysm at the anastomosis, as you saw. We did a 2-branch Terumo graft, as you see here, and he had, this is the one that I told you about earlier, had a left carotid leak at the left carotid level. We left it alone for 2 months, and this is the final CT after that. So you see there's no leak. The newer approach to this is 3 branches. 3 branches are still in trial. I don't believe they're approved yet. People even doing them now through transfemoral approach. So they would have a long steerable catheters, and they do a through and through wire to stabilize the sheath, and they access the head vessels from basically the steerable catheter, and namely the innominate and the left carotid. The subclavian usually has the same mechanism like IBE or basically a thoracic, like TBE, not IBE, I apologize, like TBE, thoracic branch endograft, as we saw before. In this study is multi-center global feasibility study for the 3 branches. Stroke rate was actually 5%, In this study, what they found that there were 5 patients among the cohort, the 39 patients that they underwent this procedure, have had access complications. The authors then decided to do these procedures percutaneously. Pretty impressive. On this slide, what you see, it's first in man total percutaneous aortic arch. And what they do, they have access from the groin, access from the subclavian, right subclavian, and access from the right brachial artery, basically as a backup. And they access the head vessels, the left carotid and subclavian through the groin with a steerable catheter, and the innominate would be accessed through the subclavian axis. When they're done with the subclavian axis, they actually stented the subclavian artery. In the past, we've done, when we have an injury to the subclavian artery, we used a perclose and sometimes a stent, a similar concept, but this is a fairly complex procedure. These people are very serious operator with a lot of experience. But I put this on to show you where we're heading in the future. So in the future, probably more and more people are going to do this, and more people will be more comfortable with doing things like that. In general, throughout the aorta or throughout the endovascular procedures. So these are evolving technologies, and I think it's worthwhile to be familiar with. And this is the graft, oftentimes with a pre-wired, and this is the 3-branch graft with as you see, the roadmap and the fusion technology. It's pretty robust fusion technology. This slide has a summary of multiple studies with a large number of patients, and basically with the aortic arch pathology and what technique was used. As you see, mainly branched endografts with Terumo, Cook, Japanese graft as well. And you see technical success varies between 84 and 100%. Stroke rate, you see stroke rate in most experienced operator is very low. Like look at the Holland group, it's 2.6, but they have a lot of experience and they're very busy. Likewise, you go down and you see group from Germany is very low, 2.7% stroke rate. Where the cohort, you see the cohort is where they have 11 patients with aneurysms. The stroke rate is astronomically high, and that's maybe due to the pathology, maybe experience, and so forth. So this slide tells me that in high volume center where people do this a lot, they have lower stroke rate. The stroke rate has decreased over the years, actually, even within the same centers. But there's a lot of heterogeneous experience. There's a lot of heterogeneous indication and methods and devices as well. So you can't really generalize this information, but one needs to know that stroke is a real thing in these procedures, and these are not just simple, minimally invasive procedures. These are complicated procedures that have mortality and morbidity as well. If you look at the SVS VQI registry, you look at zone 0, stroke rate 11%, much higher than these studies. And that makes sense because the operator are different. It's heterogeneous studies, real world, with good operator and maybe experience, maybe non-experience. This mixed, and mortality is about 6.9, so that highlights that these are serious operations, and you have to take them as such, or you have to really tackle them in a very serious way. This is a graph that shows stroke rate over the years has decreased, primarily due to prevention, stroke measures, meticulous technique, avoidance of air, CO2 flushing. I wish that we had more time to talk about measures and things that we do to decrease stroke in the urine TEVAR, but stroke rate with the high volume centers is going down on these patients. And this is a early feasibility study that done within the US for physician modified, for manufacturer and physician modified grafts. It's done at, this is by Dr. Timiran from Dallas, Texas, and you see about 5 patients, I believe, 4 PMAG, and 5 Cook devices, custom made, meaning it's made for a specific patient, and 4 PMAGs, and what you see, all triple branches, fenestrated design. They got the triple branches or fenestrated design, 100% success rate, no stroke, no spinal cord injury, access complications. Access complications, by the way, is common because usually these devices has higher French size, can be 22 and above. 1 PMAG in this study had infection and 6 endoleaks within a month, all resolved but 1. Again, these endoleaks and these type procedures, most of them go away. And this is how you do this. Is a fenestrated graft. You place a goose snare, and you cut it so you can see it, and then you oversaw it like so. And so in terms of PMAGs, and a little bit about PMAG for arch, again, in the US, people do it because lack of on-shelf devices, lack of anything else. There are a few IDEs out there, but you have to be very meticulous in measuring everything, distances between branches, sizes, angles, C-arm. You have to go back to your drawing map and draw the case very meticulously. And this is what you see the branch in the first picture on top, sewed, and here we're making, they're making, actually not me, but they're making a fenestrated, or making opening in the graft. I put this on to show you in the future pathology like depicted on the right side of the screen. It will be probably within 5, maybe 7 years or so. It would be not uncommon to see this picture with the coronary stent, with endovascular valve, ascending aorta arch grafts, with carotid subclavian bypass, or even with 3 branches. So this is something that we probably are going to see more frequently, and this is also we're going to see at 3 branches or 2 branches, like here, ascending graft, and see descending graft with a candy plug. This is something that we're probably going to see a lot of in the near future. My final thoughts on the presentation is inexperienced hand and appropriate anatomic conditions. The arch branch grafts are shown to be safe, effective, especially in reduced surgery, and they work well. Obviously, no randomized trials was done, therefore all the data that we get is retrospective or prospective or expert opinion. The management of chronic post-dissection aneurysms in the aortic arch are very, very challenging. Making intervention could be should be performed in high volume centers, because you don't want to do these in small hospitals. These are because the patient would require also state-of-the-art technology, good images, require ICU team, cardiac anesthesiologist, etc. 2-branch devices are no longer experimental, and 3 graft branches. I'm sorry, the 3-branch graft studies are underway, and percutaneous is done in very, very few centers. I think that's going to be more and more done in the future. In summary, patients should be really referred to an institution where they do this frequently. They have open and capabilities as well as endovascular capabilities, and then decisions should be made in a multidisciplinary approach fashion, tailored to this specific patient, whatever it is, it's open or endo. The root must be and the ascending must be very healthy in order to do endograft. Should not be very big, less than 38 millimeter. It's important for arch and ascending repair. Technology is still evolving. Physician-modified endografting provides custom branch and fenestrated TEVAR solution. However, it has probably more issues than manufactured made, namely endoleaks and things like that, failures. But in emergencies or urgent cases, or if you don't have access to these devices, this is the way to go, unfortunately. Trends towards inner branches more, as we spoke before, as well as transfemoral without cerebral cut down or debranching. Endovascular treatment of arch pathology is suitable for redo surgery and poor surgical candidate. This is a very true statement. For redo, we saw earlier in the slide in the part 1, mortality is quite high, and if you can do it endo, why not? This concludes this talk, and thank you very much. I apologize for the voice, but I hope you can understand what I said. If you have any questions or something, please let me know.